Hello, I'm Dr. Bridget Nash, and I'd like to welcome you to The Therapy Show, a podcast series that seeks to demystify mental health treatment. Today, I'm honored to welcome Dr. Patricia Resick, who is a professor of psychiatry and behavioral sciences at Duke University Medical Center. Dr. Resick's specialty is in understanding and treating the effects of traumatic events, particularly post-traumatic stress disorder. In 1988, she developed cognitive processing therapy for PTSD, a brief, evidence-based treatment, and has overseen multiple clinical trials. CPT is considered a first-line therapy for PTSD. The treatment manual for CPT has been translated into 12 languages and has been disseminated throughout the Department of Veterans Affairs in the U.S., Canada, Australia, and currently the Democratic Republic of Congo. Dr. Resick has written extensively on PTSD and is the author of the primary text in the field, Cognitive Processing Therapy, a comprehensive manual. Dr. Resick, welcome to The Therapy Show.
Thank you for having me.
Can you start by telling us a little bit about your personal background and professional development that led you to develop cognitive processing therapy, which is commonly referred to as CPT?
Sure. I was in graduate school and I was actually studying child therapy and parent-child interaction and went on internship to Charleston, South Carolina, to the VA and the Medical University of South Carolina. And while I was there, a couple of people were working with a group to develop one of the first rape crisis centers in the country. This was in the mid-1970s. And they asked me if I'd like to be a rape crisis counselor. And I said, sure, what's that? Being a good little graduate student, I went to the library and with another graduate student, and we looked to see what do you do with rape victims for treatment, because I was very interested in treatment. And back then, of course, we didn't have computers, so we had to sit in the library and go from 1929 to 1975 through psych abstracts, one volume at a time. There were 4 articles on the topic of rape. One of them was pastoral counseling for rape victims. One of them was victim precipitation, which means how women cause their own rapes. And then there was one how psychoanalysis got disrupted by rape. That was the kind of articles there were in the literature. There was no research. That same year that I learned to become a rape crisis counselor and go out in the middle of the night to the hospitals to sit with the rape victims while they were waiting to be examined, sometimes for hours. Because of all the National Organization for Women speak outs and so forth, the National Institute of Mental Health funded $3 million, which back in those days was a lot of money, to actually study the problem of rape. People didn't know that it was a problem. People didn't know you had symptoms or that you didn't recover from it. They thought, oh, it's just unwanted sex. And so we started coming out and saying, no, this is a serious problem. So we were studying fear and anxiety and depression. And I got involved in writing a grant application in Charleston, South Carolina. And then I went back to the University of Georgia, where I was a graduate student and was asked to work on a second grant application for that same round. And both of them got funded. That launched my career. I found that to be so much more compelling. We knew nothing about the topic. We didn't know how to treat it. We didn't know what people's reactions were, whether they recovered or not. Anything that we learned was publishable. And it grabbed me in a way that doing the parent training did not. And so I continued doing that. And of course, the thing that grabbed me the most was like, how do we treat it? What do we do when somebody has symptoms for months at a time or years at a time? So I worked on a couple of different treatment projects and was not happy with the result. I had small grants and I was working in Charleston. They were working on a brief treatment that really didn't work very well. And then I started reading the work of Aaron Beck and looked at the cognitive therapy that they were doing. And it just seemed to fit because there was a lot of exposure therapy being proposed at the time, but that seemed more like for fear and anxiety. And I kept running across rape victims who would say, I didn't think he was going to kill me, but I was so shocked that he would do this to me. I felt so betrayed. I felt so humiliated. And they were having different emotional reactions than just fear and anxiety. And so I started looking at the cognitive therapies because they really focus on all the emotions. But they didn't have a treatment for PTSD. The cognitive treatments that were being talked about were for depression to begin with, and then anxiety. And then, of course, it's moved on to all sorts of disorders. But when you're working with trauma, you've got to look back. You can't just work in the present time. And so I developed CPT in order to help them look back at the trauma and see how they had been interpreting what happened to them. And what we found was that people got stuck in their PTSD because they had decided most often that it was their fault. Most of the time people think that it's their fault because we're all raised with the just world belief. And that's the idea that as a child, we're taught if you do something bad, you're going to get punished. And if you do something good, you'll be rewarded. We don't say to children, if you misbehave, you might or might not get punished. So we all grow up with it. Our parents teach it to us, absolutes, because we can't understand subtleties as small children. So that's why we all end up with it. But what happens is when a trauma happens to you, then the first thing you do is look to yourself and say, what did I do wrong? Why am I being punished? And so that's often the very first thing that happens. Or if they can't figure out what they did wrong, maybe they'll erroneously blame someone else. And we see that a lot with child sexual abuse. Instead of blaming the perpetrator, they'll say, it's my mother's fault for not protecting me. The last person they tend to blame is the actual perpetrator. And we even see that in war zones. They'll look to their sergeant and say, he shouldn't have sent us down that road. He should have known there was going to be a buried mine, an IED in the road. Well, how could he have known? But they'll blame somebody in their periphery because that seems more controllable than blaming the actual perpetrator, which makes you feel a little more vulnerable that it could happen again. I developed CPT to help them go back and put the actual worst trauma first. And most people who come to treatment have multiple traumas, but we'll pick out the worst one, the one that causes them the most PTSD symptoms. And we'll start with that one and then move to the other ones. And often they tend to have the same kind of thoughts across multiple traumas, so you want to start with the worst. And we start teaching them how to go back in time and look at and say, what am I saying to myself about this trauma? Why do I think it happened? And what are the implications? What am I saying to myself now? And what am I saying to myself now might be an exaggeration or what we call an over-accommodation. Like, I can't trust anybody because I couldn't trust my husband. Now I can't trust anybody. Or I couldn't trust the sergeant, so now I can't trust anybody. I can't even trust my wife. So they'll have these overgeneralized beliefs about safety, trust, power and control, esteem, intimacy. But we start with why they think the event happened to begin with. And so we start with very simple worksheets where we teach them what was the event, what was the thought, what was the feeling that goes with that thought. And then we start asking questions, which we call Socratic questions, or Socratic dialogue, where we start saying, but how could you have known? Where were you? How far away were you when your friend was killed? Was it actually possible to get there? When they say, I should have saved him. And so we'll start asking a series of questions because they have to figure it out for themselves, that what they've been saying hasn't been working. And that's why they keep going in circles. So then we go through a series of worksheets where we get a little more sophisticated, teach them to ask themselves questions, and then we teach them to challenge and come up with an alternative thought that is more balanced and leads them to a different emotion.
CPT was specifically developed to treat PTSD. Can you give us a brief overview of PTSD?
PTSD was actually first introduced in 1980, which interesting us well after the war in Vietnam. So a lot of people were suffering without a label. And obviously rape victims, battered women were suffering without a label. It was that thing that happened to them. So in 1980, they introduced the concept of PTSD because we realized that rape trauma syndrome, battered women syndrome, child abuse syndrome, Vietnam veteran syndrome were all the same thing. And what that meant was that something very traumatic happened to them, not a divorce, not losing your job, not a stressor that wasn't life-threatening. Typically, it's life-threatening, or it can be something like sexual assault, which is self-threatening in a way. So these are the really big events in your life that happen rarely, at least hopefully rarely, that you've directly experienced or you've witnessed it happening to somebody else, or you find out it happened to a loved one. And then there are these clusters of symptoms that we look for. One is re-experiencing symptoms, and those are flashbacks, nightmares, feeling extremely anxious or upset when you encounter something that reminds you of the event. And it's not thinking about it intentionally. It's you're trying not to think about it, and it keeps intruding on you. So those are the re-experiencing symptoms, and those are kind of a hallmark of PTSD. And that's why we start with that first, because those are things that are really intruding on them and then cause them strong emotions, and then they try to avoid, etc. So the avoidance symptoms are that they try to do everything they can not to be reminded of the trauma. They will do whatever it takes. They'll be the busiest person on earth if they're high functioning in their PTSD. They will use drugs and alcohol. They will do whatever they can to avoid going out and being around something that reminds them of the trauma. The arousal symptoms, well, we're now calling it arousal and reactivity, are symptoms like what we call hypervigilance. That means not just being normally cautious, but always looking over your shoulder like it's about to happen. It's always about to happen. Something bad's about to happen. Exaggerated startle responses, problems with sleep, etc. And now with the reactivity symptoms, we're looking for things like self-harm behaviors, aggression. Our prisons are filled with people with PTSD who acted out, hurt somebody else, and then instead of getting in the mental health system, they ended up in prison instead. The newest cluster of symptoms are cognitive and emotional symptoms. And we finally moved PTSD out of the anxiety disorders because that was giving us tunnel vision, thinking of it just being a fear disorder. We look at the full range of emotions, guilt and shame and sadness, anger. All of those can be related to PTSD and can be the predominant emotion when you have a thought. And then the other part of it is that you have what we think of as distorted thoughts, or in CPT language, we would call them stuck points, that you're erroneously blaming yourself or other people, or you're over generalizing about the implications of the event to the rest of your life. You need to have each of those clustered for at least a month to get diagnosed with PTSD.
How would you explain CPT to a non-professional?
It sounds more complicated when you say the word cognitive. All we're talking about is thinking, means thoughts. So we know that thoughts affect feelings. If you say it's all my fault, you're going to feel guilt. If you say somebody's trying to hurt me, you're going to feel anger, or you might feel fear, and so forth. And so when we do CPT, we have them go back and look at the traumatic event and figure out what they've been saying to themselves. Is there a thought that they decided at the time? Now, if they got abused as a child, they might have said, I'm being punished. And so when a later trauma happens, they're going to go to their default thought, which is I'm being punished. And so we'll have them go back to the worst trauma and say, what do you think about it? What do you say to yourself about why it happened? And then we help them actually explore it, put it in context, and use a series of worksheets to help them start to examine what they've been saying to themselves, how they got stuck in their recovery. People can recover from their PTSD. We just have to help them get unstuck.
So who is CPT most effective for, and why should people choose a CPT intervention?
It's most effective for people with PTSD. We don't have great data that it's effective for one group more than another. Sometimes people will say education or IQ. Other studies find out that doesn't matter. We've seen some studies that say racial or ethnic group makes a difference. And then other studies who've actually adapted it for those groups don't find that to be the case. Why should people choose CPT? Because it works, first of all. It doesn't take very long. Many people, especially civilians, can finish it in less than 12 sessions. People who have been trained to think a certain way, like people in the military or veterans, because they've had certain ways of thinking pounded into them, sometimes it takes a bit longer. We're doing what we call variable length CPT now. And so what we find is that sometimes people need fewer than 12 sessions. Some people need more than 12 sessions, but it does teach you a new way to think about things. And when you change the way you think, you change the way you feel, and you find that those PTSD symptoms start to decrease and move into the background. And it's not a memory that you have to avoid anymore.
What type of training and supervision does a therapist have to receive before treating clients with CPT?
Well, we have people that we consider rostered, meaning that they've done a course, they've done a 2 or 3 day workshop, and that they've gotten supervision in CPT for 6 months. People who've already been trained in cognitive behavioral therapy might pick up the manual and read it and be able to do it just fine. We have an online course that's been launched recently, a second version of an online course that matches the treatment manual. So if somebody's already trained in cognitive therapy, this would be an easy thing for them to learn how to do. But if you want to get on the roster, you have to go through these steps. And that is available to the public so that they can pick out somebody who's actually been trained and supervised in CPT.
So what does a typical session look like?
First session would be informational, explaining to them why they have PTSD, why they got stuck in their PTSD. And they would write us what we would call an impact statement, which is why did it happen and how has it affected you? Then we would start through a series of worksheets. That's the meat of the therapy. When they bring in their practice assignments, their worksheets, we go over them and then we introduce a new worksheet that takes them the next step along the road of learning a new way of thinking, a more balanced way of thinking that's more fact-based. And so it's typically the therapist asking lots of questions of the client and the client figuring out for themselves then, oh, it wasn't my fault. I couldn't have stopped it. And then they feel a different feeling, that kind of thing. So that would be typically what we would find. Or, oh, if it's not the case that trust had anything to do with this, then why am I distrusting everyone? Then they'll start changing their behavior because they're changing their thoughts when they come up with a good alternative and balanced thought.
It sounds very interactive.
It is very interactive. The therapist really has to stay on the ball. They can't just sit back and listen. They have to put themselves in that client's shoes. And the old expression about walking in someone's moccasins, you don't know what their life is like. Even if you've experienced a trauma yourself, you don't know what it was like to be them and experience that trauma. And so you have to ask lots of questions. So the first set of questions that a therapist is going to ask is going to be a lot of clarifying questions. And where were you? And how big were you? And how big was he? And how far away were you? And you were driving down the road. Did anybody else see the mine? All these questions that you'd be asking, were they all looking? Or were you the only person who was in charge of looking for mines buried in the road or snipers or whatever it happens to be? If you were driving in a car, did you go against the red light or did you stop at the red light? Oh, the light was green and then the person T-boned you? Well, how could you have known? The therapist really has to think about what has this person been saying and what was the context. So they have to ask a lot of clarifying questions to understand what actually happened. Because the person who has PTSD doesn't want to think about it, they never go back and revisit the event again. So our first task is to make them go back and revisit the event again and get their actual facts, not what just they've been saying to themselves. I should have done something different. I should have been able to stop it. Well, okay, how could you have stopped it? Very often they'll have the Superman or the Wonder Woman fantasy that they could have done something magical to stop the event. I should have kicked him in the shins and run. Well, what would he do? Would he just stand there and wave goodbye to you? Or would he chase you down and tackle you? When people have fantasies about how they would fix things in the past, that bell you can't unring, they have these fantasies about how they could have fixed things. The therapist's job is to figure out, okay, but would that actually have worked? Is it possible you did the best thing you could do under the circumstances and it might have had a worse outcome if you had done something different? Because normally they'll have the fantasy that it all would have come out fine. They never consider the fact they didn't have control over the event and it was going to happen in spite of them, not because of them.
It seems like it would be very validating for somebody to have a therapist who's really interested in tracking the story and understanding what happened from multiple points of view. And it wouldn't be very intrusive. It would be very validating and done in a very careful way to make the client feel like they were listened to.
Absolutely. You don't want to come across like some kind of district attorney saying, where were you on the night of the 23rd? No, you have to take on a very gentle and curious kind of stance and puzzled. I mean, you're always in a one-down position as the therapist because you have no idea what it is like to be them in that situation. So you always want to come across as being supportive and you're on their side even when they're not. It's a series of gentle questions that are going to be puzzled and I don't understand. Explain this to me. You never want to take one side of their own conflict and try to convince somebody. It does no good to say it wasn't your fault. People in their lives, I'm sure, have said it wasn't your fault. And they'll say, you don't know, you weren't there. Or what kind of idiot are you? You've always got to revert back to questions. Well, tell me what it was like. So if you make a mistake and try to convince somebody because you get overeager, the therapist has to back off and say, oh, I was just so eager for you to get better that I was getting too pushy. Let's back off a little bit. Clearly, I don't understand. Why didn't you explain to me what it was like?
That's the importance of the training, really understanding how to do it correctly.
Yeah, to ask questions. And as I said, for the client to put themselves back there in a safe and supportive environment and reminding them that this is just a memory. They are not now currently in danger, and that they can revisit that memory anytime they want, and they can look at the facts, and they can think about what they've been saying to themselves and figure out, is that actually accurate or not? Could they have done that? Could they have stopped the event? It's a process of asking questions and then looking for the real evidence, and then eventually having them come up with, well, what else could you say to yourself in that case? Well, it wasn't my fault. There wasn't anything I could do. It happened not because of me. It happened because of that other person. And they might switch from feeling guilty to feeling anger, which is a natural emotion.
Yes.
Now, they don't have to get stuck in that anger again, but maybe they need that opportunity to feel anger at a perpetrator, especially when people around them are all saying, put it behind you, forget about it, try not to think about it, move on. You've got to let them stop and not move on for a few minutes and let them think about it. Some people, it's a very slow process. Some people have this aha moment and they'll just like, oh, I can't believe I was saying that. And there's something about those worksheets that are really important because they see it written down in black and white and they can look at it. They can look at what they've been saying all this time. And it's amazing to see when they like, I've been saying this.
After the trauma and after they take on those negative beliefs, that becomes a lot of times the lens in which they look at the world. Is that correct?
Yeah, absolutely. They'll look at everybody that way. That's where I say that not trusting anybody or the world is entirely dangerous. I'm about to be attacked. If you have that thought, you're going to behave as if you're about to be attacked at any given moment, or that you're a worthless person, or that everything is your fault. So no matter what happens, even if it happens to somebody else, down the street, somehow you figure out it had to be your fault somehow because that's the way you think. So yeah, it is a filter that goes up. And if you think it long enough, it becomes what we call a core belief then. Especially, I think this is the case when you've been abused as a child emotionally emotional abuse always goes in hand with physical abuse. They have to have an excuse for why they're physically abusing you. So they will say, this is all your fault. You made me do it. You worthless, stupid child. And so if they grow up thinking I'm worthless, I'm stupid, that becomes what we call a core belief. And so they'll view everything through that lens. And so if another trauma happens to them, they'll say, it happened because I'm stupid. It happened because I'm worthless, or I'm no good, or these things will always happen to me. I've had clients call themselves trauma magnets. Bad things always happen to me. It's because somehow they haven't figured out that they can get out of some situations and they dissociate and freeze instead of running.
So what's the average length of treatment for somebody working with CPT? And are there different phases of recovery over that course of treatment?
I wouldn't necessarily call it phases, but I originally developed it as a 12-session treatment. So in research, that's most often you'll see it as a 12-session therapy. But more recently, there have been two studies, one with civilians, and I just completed a study that's under review now with active duty military. Tara Golofsky, who did the first study with civilians, found that the majority of them did not even need 12 sessions. On average, they needed 9 sessions. We just finished a texting therapy where the therapist actually does it with back and forth with texting, and we give them a manual and help walk them through a manual. If they don't have time to come in for therapy and drive in and park and all that stuff, they may not get therapy. So we're hoping to get more funding to study this texting therapy. But the people who did it and ran with it did it in about 3 weeks. So we're looking at much shorter therapies now. The longer you drag it out, if you have them coming in once a week for 12 sessions, you're going to get a higher dropout rate than if you do it twice a week. You're going to get a higher dropout rate than if you do it very fast. We don't want people dropping out of therapy because they have busy lives and can't take the time or start avoiding. They miss a session and then now it's 2 weeks and now they haven't done their practice assignments and they're afraid to come back and that kind of thing. So we want to do it now. Variable length can be anywhere from 4 or 5 sessions up to 18 or 20 sessions, depending on probably their trauma history. It might have to do with how much cognitive flexibility they have. Can they change their minds easily? Or are they stubborn and stuck in their ways? I actually had a client say to me, I know my thoughts don't make sense, but they're my thoughts. I don't want to let go of them. If somebody says, I've never had anything, but these are my thoughts, I'm going to stick with them. The therapist is going to have to take a little bit longer to help them see that those aren't functioning for them. How well has that been working for you? You still have PTSD. after all these years.
I call that the sell job. That's when the therapist has to sell you on the change.
Absolutely. I think the sell job is important. I think people need to understand that for a therapy to work, they've really got to engage in it. This is a therapy that works, but not without the client. I can't do it with my hands tied behind my back. We can't do it if they don't do the practice assignments. I would be more likely to fire the client if they come in 3 weeks in a row and haven't done the practice assignments and say, come back when you're ready. Because I don't want to waste a wonderful therapy on somebody who's going to say, this didn't work when they didn't work it.
But I think that is the balance, because the therapist has to really give you a therapy that works, something like CPT that's been proven to work. But it also cannot work unless the client does their part. And I think that's the collaboration between client and therapist. And that's what my next question, what skills, habits, or tactics can patients adopt either during their sessions or in between sessions to improve the effectiveness of CPT? I think that's what you're talking about here.
Absolutely. I'm talking about them attending the sessions, first of all, and doing the practice assignments. And I think sometimes therapists get a little lax. They'll bring in one worksheet when it's been 5 days. And what they should be saying is, like, you only did one worksheet. Why didn't you do 5, one a day? That would only take you about 10 minutes to do. And so I think the therapist has to stay on top of the fact that the meat of the therapy are the worksheets. And the more that they do, the more they're going to learn the skills of changing their thoughts and changing their emotions. And so I think the client has to be invested in it. They have to do the practice assignments, just like learning a new language or learning to tie your shoes or learning to drive a car. You've got to practice. This is not a skill we learn in school, unfortunately. Balanced thinking 101 is not taught in elementary school, high school, college, sadly. And I think in the last 4 years, we've gotten very confused about what are facts, because there's a whole environment of alternative facts, which aren't facts, they're lies. And I think people have to stop and really figure out, how do you figure out what's the evidence for something? Would it hold up in a court of law? And so that's the way we'll actually talk to clients. Would this thought hold up in a court of law? Would other people agree to this, that you should have been able to run 350 yards and save the person and pull them out of that burning car in 2 seconds? I think a jury would say no. It's not your fault. You couldn't have pulled them out, and it wasn't your fault the car had exploded up ahead of you. So I think we have to have them do the practice assignments. They have to learn these new skills, new ways of thinking, where they ask themselves questions. Does this make sense? Am I jumping to conclusions? Am I overgeneralizing? Am I doing emotional reasoning? I feel guilty, so I must have done something wrong. So we'll teach them all sorts of ways of thinking about their traumatic event that's a little bit different, and they can pick apart what they've been saying to themselves so that they can come up with an alternative that is more fact-based, that is more based on actual evidence and what actually happened. But that's what they have to do, is they have to engage in the therapy and do the practice assignments and come to the sessions.
And I think this is where it ties into the lens. When you have a traumatic event, you have a negative thought or belief about the world or yourself. And then when you put that thought on trial and you examine the evidence for it being true or not true, and you find out that it's not true, then you find that the lens in which you view the world is cleared up, is shined in a new way. Now you have a new lens for seeing the world, and then your life can unfold in a different way.
And especially if someone has a core belief, that's what you're calling that lens. If you always say, it's all my fault, everything is all my fault, after they do a series of worksheets where they keep coming to their stuck point, their thought, it's all my fault that this happened. They can do that on everyday events. They can do that on all sorts of traumatic events. And if it always comes out to it wasn't their fault, eventually it's going to fall under the weight of the evidence. And they're going to say, maybe things aren't all my fault. If I do something intentionally, we use the term intent a lot in CPT. Was this unforeseeable? Did you play a role in it? Did you intend the outcome? Now, we have people who did intend the outcome and do have PTSD, and we will not let them off the hook for that. Yeah, you intended the outcome. And that's why you're in prison now. But that doesn't have anything to do with why you were abused as a child. Let's separate those things out. And so we will hold people accountable for the things they intended. But if they didn't intend the outcome, did they have a role in it? Were they drunk driving? They didn't intend to kill somebody, but they did have some responsibility. They had a role and they have to own that. But most of the time with PTSD, we're seeing people where the event was completely unforeseeable. And they're trying to own it as if they must have been able to see it in advance. They should have had a crystal ball. They should have known it was going to happen, or that that person couldn't have been trusted, or whatever it happens to be, or that they shouldn't have had a drink that night. Well, what about everybody else around you? Oh, they were all drinking too. And were they all attacked? No. Or I was wearing a short skirt. How was every other woman in the bar dressed? They were all wearing short skirts. So they were all attacked? No. Okay, so maybe that's irrelevant. Let's go back and look at why you were attacked. Well, because I was alone with that person. That might account for it. And that person felt like doing it that day and could get away with it. They looked around, thought they could do it, and they did it. That's a whole different way of looking at it.
So are there any obstacles that prevent people from seeing the full benefits of CPT?
Quitting. We have gotten rid of so many of the things we used to rule out in research projects. We used to rule out alcohol use. Now we don't. We used to rule out people who had a history of psychosis. If they're stable on their medications, we go ahead. Or bipolar disorder, we go ahead if they're stable on their medications. Even suicidality, if they are not imminently suicidal. If I ruled out everybody who had suicidal thoughts at some point, I would have never finished my first study because it's so common. I mean, that's the ultimate avoidance, isn't it? Mm-hmm. And drinking is avoidance. So we're realizing, why are we ruling these people out or saying they have to be sober for 6 months? They're going to relapse on their PTSD in the meantime if we tell them they have to stay sober, because as soon as they have a flashback or a nightmare, they're going to do their go-to, which is to drink or use drugs. So we have gotten rid of a lot of the things we used to think were rule-outs. We're doing it with people with traumatic brain injury. And the one thing we found is they do better with individual therapy than group therapy. So I would say do individual therapy with people with traumatic brain injury. They may need a little longer. They may need simplified worksheets, which we have in the manual. So there are very few things I would think that would be obstacles except for the patient themselves not coming to the therapy and not doing the practice assignments.
Can you share any poignant examples where CPT had a major impact in someone's life?
Thousands. I've been contacted 10 years later after I treated a client who said, I never told you, but, I'm getting back to you now because I wanted to let you know what an impact you had on my life. I'm married and I have children. I rarely think about it, but it was the anniversary of it. And I suddenly thought, I never thanked you properly. How much did it change my life? One that stands out to me was early in the war, when I first started working at the VA, which was in the early 2000s, and we ended up in Iraq and Afghanistan. I went and trained some military providers, some therapists, and one of them was so thrilled that he emailed me. He had heard back from one of his patients he had treated with CPT who had gotten redeployed to Afghanistan, who had another major trauma. And he was so excited that he didn't get PTSD again that he wrote his therapist. The therapist wrote me and said, I'm so excited. This didn't just fix his old PTSD. It prevented him from getting new PTSD because he thought about it totally differently.
And he owned the skills.
And he owned the skills. He had mastered it. He owned the skills and he took on the next life event that happened to him in a totally different way. I had a therapist come up to me one time when I was doing a conference. I was just talking about women and PTSD in the military. And I wasn't talking about treatment particularly, but he came up to me afterwards and said, "You saved my career." And I went, "What?" He said, "I was ready to quit. I was working at this military base and I was feeling so useless and so helpless. And then I learned how to do CPT and my clients were getting better. My patients were getting better." And he said, "I didn't quit. I am so excited to go to work today and do this therapy." So it totally changed the way he did therapy. And he credited me with saving his career because he was about to quit and do something else. So those are 3 poignant examples from 3 different viewpoints.
And as a therapist, when you learn these therapies like CPT that work, you do have a renewed sense of the work and the ability to actually help somebody change their lives over time. It is very empowering for the therapist.
Yeah, there's so many disorders where people tend to relapse. But we just don't see relapse in PTSD. And it's funny because when I started working with substance abuse, people would talk about days till relapse as one of the outcome measures. And I thought, oh, that is so depressing. I did one study where we tracked people out to 5 to 10 years later, and they hadn't relapsed from their PTSD. And some of them had had other major life events happen to them. So you don't see big, long follow-ups now with PTSD studies of any kind, because once you've treated them and they don't have PTSD anymore, they don't relapse. That makes it very exciting as a therapist to have a therapy that works. Mm-hmm. And they move on with their life and they do other things and they get on with living their lives and putting it behind them. So it's exciting for the therapist. Of course, it's exciting for the client. The only time they have is regret that they didn't come to therapy sooner.
Agreed. Yeah. If you had a magic wand and could improve one thing about mental health treatment today, what would that be?
One is to get rid of the stigma. There's so much stigma about mental health. They'll try anything before they'll go to a therapist, as if that's the last possible choice. I mean, they'll consider suicide before going to a therapist. They'll become an alcoholic before going to a therapist. So I wish we could get rid of the stigma of going to therapy. There's also these barriers that are there so people can't go to therapy. It's not treated like a medical problem. If you broke your arm, you go to a doctor. If you've got PTSD, go to a therapist. It should be like an everyday thing so that we get rid of it. And it's paid for in our insurance policies or mental health clinics around the country. I mean, we used to have the idea that we were going to have mental health clinics all over the country, and that sort of fell by the wayside, where people could get treatment and not end up homeless and suffering. Actually, I was just hearing today, Kamala Harris was talking about the importance of mental health. And I thought, I hope they take that up, because I think that's so important as much as physical health. And we know that if you treat your PTSD, your physical health gets better. So the two ought to go hand in hand.
I agree. The mind and the body are not two separate things. They're one thing.
No, they're not. One of the studies we're conducting right now is looking at the effects of CPT on cardiac functioning. We know that people die of who have PTSD, have cardiac problems. The thing is, can we reverse that? Can we fix that? So that's one of the things we're looking at now. If we get people who are between 40 and 65 years old CPT, can we reverse some of those signs of cardiac functioning?
How can my audience learn more about your work, either online or in print? I want to ask you mentioned about some of the available online resources for the non-professional, for the non-therapist, because during COVID, it's really important for people to be able to access these resources.
Well, actually, one of the good things is we had already studied telehealth prior to the pandemic. So we know that it works equally well if you do it through a telehealth, through your computer or through an iPad, something like that. People have even done it on the phone if they needed to with FaceTime. There is a website that's for both providers and for patients where people can find a provider, and that's called CPT for PTSD, all small letters, .com. They can go and click on providers and they can look for country, they can look for state, they can look for somebody who's near them. But the nice thing about telehealth is as long as somebody's licensed in your state, you could get treatment from somebody who lives 100 miles away or 200 miles away. And the people who are listed on that provider roster should be people who are accepting referrals. And now they might be very busy right now, but you might have to check more than one. But that's one of the fastest ways to find out somebody who's a provider in CPT is to go to cptforptsd.com.
It's the kind of therapy that really does well with telehealth.
Oh, yeah, absolutely. Getting the worksheets, holding them up or emailing them. Or there's also the VA's National Center for PTSD developed an app for patients that's called CPT Coach. And that's free through iTunes. That you can do with a therapist. It's not set up as a book so that you can do it without. We're actually going to be starting to work on a self-help book. That's not available yet, but I hope it will be. If anybody is thinking about getting therapy and they're just not sure what it would be like, I would suggest that if you go into that same website, cptforptsd.com, and look at resources, you can go right there and see This American Life did a podcast about CPT in action. And it's called 10 Sessions. One of our first trainers, in fact, she was my graduate student eons ago. She's now a full professor, but she agreed to have her therapy with this reporter recorded. And I have never heard anything like this before, where you can actually be in the room with the therapist and the patient. You can hear what CPT is like. Anybody can get to. They just replayed it recently, and I just saw a whole lot of traffic on Twitter, and I thought, why are they talking about that again? It's because This American Life replayed it or rebroadcast it. Just go to This American Life, 10 sessions, and you can hear what CPT sounds like if you're a little skittish about trying it, and then go to the website and find a provider.
I loved that podcast. Listening to how well she navigated those sessions as a therapist, and I am a clinician, so I was looking from that perspective. It was really beautifully done, and her skills are phenomenal.
Yes, she's a great therapist.
Dr. Resick, on behalf of myself, my listeners, and all of the people that you've helped through your work, I want to just say that you've taken this field so far with your CPT model. I want to thank you for your contributions to mental health treatment and for taking the time out of your busy schedule to help me and my audience better understand the field of cognitive processing therapy.
Thank you. It's been my pleasure.
So be sure to check out my website, therapyshow.com, which has many resources about mental health, including a page dedicated to CPT. There you will also find how to submit questions, stories, or insights that you have about the mental health system, or suggestions about who else I can interview and how I can improve the show. I'd like to close by reminding our listeners to please subscribe, share, and review this podcast so you, someone you love, and people around the world can gain more benefit from therapy. There is no need to suffer in silence. Get the help that you need to create the life that you want.